This episode is adapted from a clinician-written article on Mentalyc and brought to life in audio for therapists who prefer listening on the go.
I love that we're doing this. It's so much easier to absorb this stuff while driving or between sessions.
Right? And this particular piece was written by Adesoa Olagir, LCEP, and we're just really excited to feature their perspective here.
Fantastic. I'm ready to dive in.
Okay, so just for a little context for anyone new to us, since the article comes from Mentalyc, it helps to know it's a platform designed to make clinical documentation more manageable and insightful for therapists.
A worthy goal, for sure. So, what are we getting into today?
Okay, so let's start here. You know that feeling. You're in a session and you ask a question and the answer you get is technically correct, but it feels hollow.
Oh, I know that feeling intimately. It's like the client is handing you a carefully curated plastic wrap version of their experience. There's no air in it.
Exactly. No air in it. That's the perfect way to put it. And your gut is just screaming, there is so much more under this. But you can't push because that would just build the wall higher.
Right, because the second you push, you confirm the client's fear, the fear that they're being judged, that they need to perform, that they need to give the right answer. And that's where this whole conversation around stigma and bias really begins, isn't it? It's not just some abstract societal problem. It lives and breathes right there in the therapy room, in those silent moments.
It really does. We talk about stigma as this big external force, and it is, but when it shows up in our space, it's through shame. It's the client's fear that if they show you the messy, unfiltered truth of their experience, you'll label them. You'll see the diagnoses and not the person.
And that fear is so powerful. It keeps people from seeking help in the first place. Or, like we were saying, it makes them withhold the very information we need to actually help them. It's a vicious cycle. They need help, but the fear of being judged for needing help prevents them from getting it effectively.
It's a total catch-22. And it's been this way for, well, forever. But what really gets me is thinking about our role in it. Because our communication, our choice of words, our tone, it can either reinforce that wall or it can hand the client a sledgehammer to start taking it down themselves.
I like that metaphor. We're not taking it down for them. We're creating the safety for them to feel empowered to do it. And that's where the conversation has to shift from the client stigma to our bias, right? That's the harder part to look at.
Yeah, that is the harder part because stigma is what they walk in with. Bias is what we might be meeting them with, often without even realizing it.
Implicit bias, the stuff that's baked into our subconscious from the society we live in, the media we consume, the systems we were trained in. It's not about being a bad therapist. It's about being a human with a brain that loves shortcuts and stereotypes because it's efficient. And those shortcuts can be so harmful in our line of work.
So harmful. It can be based on anything: race, gender, socioeconomic status, weight, a past diagnosis in their chart. And if we don't actively pay attention to the messages we've internalized, they will leak out. Unconsciously, they will shape our questions, our interpretations, and our treatment plans.
And the client feels it. They may not be able to name it. They might just think, I don't feel comfortable with this person, or I feel like they're not really getting me. They just know they don't feel seen. They feel categorized.
Which brings us to something that feels so basic, but I think we can never talk about it enough: person-centered language. It's one of the most immediate, concrete ways to start dismantling this stuff in our own practice.
Yes. The classic example, right? Not a diabetic client, but a client living with diabetes. It seems like such a small shift in semantics, but it's a seismic shift in perspective.
It's huge because one is an identity, a label that contains the whole person. The other is an experience, a condition that a person has, but it isn't who they are. One is a static box, the other is a dynamic experience. It puts the person, their humanity, back in front of the diagnosis.
And it changes how we think, too. When you say a person with bipolar disorder, you're already priming your brain to remember there is a whole person there with strengths, a history, a personality, relationships, all of it. If you just say a bipolar, you're priming your brain to look for symptoms and deficits. You're already narrowing your own field of vision.
You absolutely are. And then you start to wonder, am I doing this consistently? Are there certain clients or diagnoses where I slip into that labeling language more often? It's hard to track that in the moment when you're just trying to be present with the person in front of you.
It's nearly impossible to track in the moment. Your focus should be on the client, not on self-monitoring your every syllable. That's why the reflection has to happen after the session. That's where the real learning and course correction happens.
Exactly. And it's funny you say that, because I was exploring a feature in Mentalyc that's built for this exact kind of reflection. It's called Alliance Genie. And the whole point is to help you reflect on your own documentation, your notes, to see those patterns. It doesn't listen to your sessions or anything like that, but it can surface insights from what you've written, like, hey, you tend to use more pathologizing language here, or you focused heavily on deficits in this note. It acts like a mirror for your own clinical lens.
Oh, that's fascinating. So it's not telling you what to do, it's just reflecting your own patterns back to you from your notes. That's the kind of support that actually helps you grow instead of just telling you you're doing it wrong.
Exactly. It's about strengthening your own clinical judgment, not replacing it. Quick pause here. If this part of the work feels familiar, that struggle to see your own blind spots, Mentalyc can help. Its Alliance Genie feature supports your documentation and clinical reflection while staying fully HIPAA and SOC 2 compliant. You can explore it at Mentalyc.com.
That's a really practical application of technology. Okay, so we've talked about the problem, stigma and bias, and the importance of language. Let's get even more practical. What do we do in the room to build that trust and make it safe for clients to be vulnerable?
I think it starts with the most foundational skill we have, active listening. But not just quiet, nodding listening. I mean truly empathetic, engaged listening. It's about the questions we ask.
Moving from closed-ended to open-ended questions, instead of, did that make you sad, which invites a simple yes or no and subtly implies you already have a theory, shifting to, how did that land for you? Or, what was that experience like for you?
Yes, that simple shift from did you to what was it like is an invitation. It says, I don't know the answer. You are the expert on your experience, and I'm here to learn. Think about that beautiful, simple, powerful first question. What would you like to talk about today?
It's the ultimate transfer of power. It's saying, this is your space, your agenda leads. And then whatever they bring, our job is to meet it with non-judgmental curiosity. And that's not just in our words, it's in our body.
Oh, 100%. If you ask, what would you like to talk about today while glancing at the clock or shuffling papers, the words are meaningless. But if you ask it while leaning in slightly with an open posture and a soft, steady gaze, that nonverbal cue screams, I am here, I am ready, I am with you.
And then, when they're done sharing a piece of their story, the next crucial step is reflection, summarizing what you heard, not just parroting it back, but synthesizing it. So what I think I'm hearing is that you felt both incredible relief and also a deep sense of guilt at the same time. Is that right?
That does two amazing things at once. First, it tells the client, I didn't just hear your words, I heard the meaning and the emotion behind them. It proves you are truly listening. And second, it gives them a chance to correct you, to say, well, not exactly guilt, it was more like responsibility. And boom, you're going deeper. You're co-creating understanding.
You're building the alliance brick by brick, and all of this is an antidote to bias. Because when you're that curious and that focused on the client's unique experience, your preconceived notions have less room to operate. You're not trying to fit them into a box. You're helping them describe the shape of their own experience.
Which brings us back to working on our own implicit bias. Because even with the best intentions, those blind spots can persist. How do we actively work on that outside of the session?
Well, there are formal tools out there, like the implicit association tests, the IATs, and they can be really eye-opening, just as a personal starting point to see where some of your hidden associations might lie. But I think the real ongoing work happens in community. It happens in peer consultation and case reviews.
Yes, creating a space with colleagues where it's safe to be vulnerable, where you can say, hey, I'm feeling really stuck with this client, and I have a feeling it might have something to do with my own stuff. Can I talk this through with you? What might I be missing?
Exactly. A culture of non-judgmental accountability among peers, where we can discuss real cases and challenge each other respectfully. I notice you describe this client's behavior as attention-seeking. I wonder what it would look like if we reframed that as connection-seeking. Just little shifts that open up new therapeutic avenues.
And that really points to the responsibility of the larger organization or practice, too. It's not just on us as individual therapists to solve this. The systems we work in have to foster this culture.
Oh, absolutely. Practices need to have inclusive policies. They need to prioritize diversity in their hiring, not just as a token, but because a multitude of perspectives leads to more inclusive and effective care. They need to provide ongoing, meaningful training on cultural competence and implicit bias, making these conversations normal and expected, not a one-off, check-the-box HR requirement.
And it extends to community outreach, too, normalizing conversations about mental health and chronic conditions in the wider community. When we talk about these things openly and with respectful language in workshops or public forums, we help reduce the very stigma that makes clients afraid to walk into our offices in the first place.
It's all so interconnected. Because when we fail at this, when a client perceives stigma or bias from us, the consequences are so real. They withhold that vital information we talked about. Or worse, they just disappear. They drop out of therapy, maybe avoiding it for years until the crisis hits.
And the discrepancy in care is staggering. If a therapist unconsciously thinks a client from a certain background is exaggerating their pain, whether it's physical or emotional, they might not provide the appropriate level of care. That can lead to prolonged suffering, misdiagnosis, serious health problems. It's a matter of life and health.
And it creates this cycle of frustration and shame. When clients feel repeatedly dismissed or judged, they start to internalize that stigma. They start to believe, maybe I am broken. Maybe I am too much. And that just worsens the very conditions they came to us to heal.
And let's not forget the impact on us, the providers. Working in a system or even just in a private practice where you feel like you can't address these biases, where you feel powerless, that is a direct path to burnout. It's a moral injury. You feel complicit in a system that's causing harm, and that erodes your passion for the work.
That's so true. The stress of feeling like you're part of an unfair system is immense. And that stress inevitably affects your ability to be present and effective with your other clients. It's not just a client problem. It's a provider wellness problem, too.
So this is a huge, complex topic. We've talked about stigma, bias, language, listening, self-reflection, and systemic change. If we were to boil all this down for a clinician listening right now who might be feeling a little overwhelmed by it all, what is one single practical thing they could do today to start moving the needle?
I think it starts with a moment of quiet, honest reflection at the end of the day. Forget trying to fix everything at once. Just ask yourself one question about your sessions from that day. Where did I feel a disconnect with the client? And then the follow-up question, what was my part in that? No judgment, just curiosity. Was it my language, my body language, a question I asked, an assumption I made? Just starting with that small personal inquiry can open up a world of insight.
That's so powerful. It's not about blame, it's about awareness. And that is exactly the kind of personal reflection that tools can support, not replace. It's about creating a space for you to see your own work more clearly.
A mirror, not a critic. That's what we need.
Exactly. And if you want support in tracking those kinds of alliance patterns across your sessions, that's precisely what the Alliance Genie can help you reflect on, using just your own notes to offer insights without ever storing any session recordings.